I think let us start. So, good morning, good afternoon, and good evening, everyone. So, thank you for joining us. So, my name is Tersit. I'm a global primary care program lead at the Institute. So, for colleagues and participants who joined us today for the first time. So, International Institute for Primary Healthcare Ethiopia is established by the Ministry of Health of Ethiopia. So, it's majorly working on primary healthcare system strengthened within Ethiopia and other low and middle income countries in focusing on capacity building, cross-country learning, South-South collaborations, technical supports, evidence generation, and advocacy. So this primary healthcare webinar series has been conducted for the last 4 years now. So which is focusing on mostly in different primary healthcare topics that could help for countries, especially for low and middle income countries, to learn from each other so that they could strengthen their primary healthcare system. So as part of the efforts that the Institute is doing on such system strengthening efforts, this is one of a great work that the Institute is working to create a platform for the countries to learn to each other and share best practices and other learning and experiences. So today we bring you a very good, I think, a very important agenda for discussion and for to share some experiences to how the PHC-oriented researches will be translated into action. So we'll have senior experts from Hawkins and from Project of Ethiopia to share the global perspectives on such PHC-oriented researches, how they can be translated to action to improve the primary care system or health system at large, and also we'll have an experience how the pathway analysis model is used in Ethiopia. Then the experience will be shared from the project. So my colleague, Professor Gatenet, will be moderating this session. So it's been an honor to have Professor Gatenet here today, and also an honor for me to introduce him for you. So Professor Gatenet Mitike is a medical doctor and holds an MPH and PhD. In public health, he is a senior researcher at IPHC with extensive experience in health research, teaching, and consultancy services, and served as an honorary adjunct professor at Bahar Dar University. He has spent more than 18 years in academia, including serving as a dean of School of Public Health at Addis Ababa University. He leads the implementation research section with a knowledge generation and management team, strengthening implementation research capacity to inform policy, primary healthcare policy program and program improvements. His work focuses on generating, synthesizing, and translating evidence into policy and practice through publication, policy briefs, workshops, and collaboration with national and international partners. So it's an honor to have Professor Gaetana today to moderate the session. So I will directly hand it to Professor Gaetana to continue with moderating the session. Over to you, Professor.
Thank you, Tersit, for your generous introduction. Good morning, good afternoon, and for some of you, maybe good evening, and welcome to this webinar, PHC-oriented research for action, insights from a global perspective and Ethiopia's pathways segmental experience. As you have seen probably, we'll see the PHC-oriented research, how it looks like, and also the global and what it means, also the global experience on PHC-oriented research, and also Ethiopia's pathway segmentation experience. And then we'll have some key takeaways at the end. I think this is a very important and timely webinar. In one way or another, many of us have been engaged in this PHC-oriented research activities, and it's good to know what the global developments are and what the experiences are in Ethiopia as well, so that we can share experiences and we can further develop our capacity. So for this webinar presentation, we have two distinguished experts, and it's a pleasure for me to introduce maybe the first one who would give us the global experience, Dr. Shivam Gupta. Dr. Shivam is an associate professor at Johns Hopkins Bloomberg School of Public Health. Dr. Shivam is a health systems expert and clinician with 15 years of postdoctoral experience across research, policy, and program implementation. His work focuses on strengthening primary healthcare and building resilient, people-centered health systems in low and middle-income countries. At Johns Hopkins Bloomberg School of Public Health, he leads research advancing PHC outcome measurement, service integration, quality of care, supply chain continuity, and community health worker system support. Previously, he served as Senior Specialist for Resilient and Sustainable Systems for Health at the Global Fund, contributing the design and measurement of major global health investments. Now, the floor is yours, Dr. Shiva.
Thank you, Professor Getnet. Thank you, everyone, for this opportunity. I'm going to share my screen and then I can talk about the topic at hand. Thank you very much. So let me share my screen. Biru, I think so. I'll put it on full screen mode, so hopefully that will not distort the thing. So I'm assuming my full screen mode is visible to everyone, and everybody can hear me too. Good, thank you. So thank you very much to everyone for joining this presentation, and thank you to PHC to invite me for this. So for this talk, I'll specifically talk about some of the work that I did at Global Fund in terms of using research for evidence, focusing on specifically in primary healthcare, specifically on the issues of integration and quality of care. Some of the work that I did at Global Fund between 2021 and 2024. So as most of you might know, that the Global Fund primarily funds HIV, TB, malaria programs in over 100 low and middle income countries. And simultaneously, it also invests in health system strengthening. So health worker capacity building, lab strengthening, supply chains, and others. Global Fund works on these 6-year strategies, strategy cycles. So the current strategy cycle is this 2023 to 2028. And in this strategy document, people-centered integrated systems for health is one of the 4 core strategic objectives. So this issue of vertical disease outcomes, in this case, HIV, TB, malaria, ultimately depend whether the primary healthcare platforms or the system behind is actually delivering integrated good quality care. And this has been highlighted in several key reports, more specifically the Astana Declaration and the WHO PHC report. So the question that I faced at Global Fund at the time was, how do we know whether the system investments that the Global Fund is making translate into better care at the point of service delivery? So while Global Fund invests in both disease programs as well as the system strengthening, but how do we know whether these system investments are actually translating into better health outcomes? And so that is sort of the question that this talk will talk about, and the work that I'm going to talk about. So now the question of why we focused on integration and quality of care was sort of central to this work. So what we have seen more and more in the literature is that quality, not just access, drive outcomes. And the Lancet Global Health System Commission report on high quality health system provides very clear evidence of this in addition to the WHO PHC report. And the other problem that we see in literature all the time is the fragmented care that pregnant women and other uh, patients receive at the point of care. So this would be, whether they are coming for ANC, HIV, TB, malaria, rather than one coordinated encounter, they get this fragmented care. One second, I need to. So gonna make this smaller. Okay, yeah. So the Lancet Global Health Commission talked extensively about this issue where how how the health system quality can be linked is at three levels, and the place where sort of the measurement gaps exist are in this middle, the process of care. So um, the issue that structural readiness, structural availability, access is not adequate to deliver high quality integrated care. What we need to do is to focus on measurement of process of care in terms of both at systems level and individual level. And what it needs is direct measurement of these processes of care, which then leads to better quality, measured and better outcomes for the health system in terms of confidence in system, better health outcomes, and economic benefit. So, sorry, where did I? So while we face sort of this gap around how do we, the question the Global Fund grappling around how do the disease investments and system investments contribute to disease outcomes, and the gap in measurement of primary healthcare processes, specifically integration, quality of care, people-centered care, and that being a strategic objective for the Global Fund in the current strategy allowed us to come up with the measurement framework. So this became a measurable result domain for Global Fund rather than a theoretical or a conceptual concept. And so building on the strategic mandate, uh, we developed a framework and subsequently a measurement tool, and then did the measurement of these processes of care around integration, quality, people-centered care. So this translates what matters into what we can actually measure and try and improve performance on. So this is a conceptual framework. I'll not go into much detail, but essentially on the left-hand side, we see the investments that are typically made and the short-term outcomes that relate to health system strengthening. And on the right side are some of the investments and short-term outcomes for specific vertical diseases, in this case, HIV, TB, malaria. And in the middle, we see this mutually beneficial relationship between health system strengthening investments and disease investments, which are in turn related to medium and long-term outcomes. The medium-term outcome in case of Global Fund strategy became the integrated people-centered health services from a health system point of view, while from the disease point of view, things like reduced transmission, increased coverage. And then the long-term outcomes in terms of resilient and sustainable systems from a systems point of view, and the long-term outcomes in terms of strengthening of HIV, TB, malaria services. So this mutually beneficial relationship, how investments in health systems in turn contribute to better disease outcomes through better integration, better quality, and more people-centered services. So the conceptual linkage came from here. Now then, we actually had to measure it because it is part of the strategic key performance indicators for the Global Fund. So what? So then this basically led us to look at what is available in terms of measurement tools for us. And so what we saw is, you can see in sort of this middle column, the primary focus of existing multi-country health facility assessments was on structural readiness, and mostly focus on disease or input specific. How much do they focus on patient voice or patient perception was limited, and they are typically SARA, SPA, WHO's harmonized health facility assessment are very resource intensive and rarely repeated at frequent intervals in countries, and focus on basically facility based staff only. So what we needed was focusing on service delivery processes and outcomes, cross-cutting issues of integration and quality of care, measuring patient-reported experience, as well as a tool or a methodology that was agile, lower cost, and could be repeated across a strategy cycle. And very importantly, to get the community health worker perspective, community health worker readiness as well, because they're part of the health system as well. So we basically ended up designing a fit for purpose tool called the Targeted Health Facility Assessment, which measured these 11 indicators. Four were the key performance indicators for the Global Fund strategy, focusing on provision of integrated people-centered high-quality services, provision of integrated supportive supervision, specifically HIV, TB, malaria services integrated and offered to pregnant women, systems readiness for community health workers. And then in addition, 7 programmatic indicators, as in these indicators would allow the grant monitoring, the grants that Global Fund is giving in the current grant cycle 7 and grant cycle 8, part of this 2023-28 strategy. So some of these indicators on diagnostics, oxygen, were also included in this targeted HFA. What is distinctive is the very clear inclusion of the patient-reported experience measures and a dedicated community health worker module. And I mean, the whole tool and everything is available in public domain. I'll provide a reference in a subsequent slide. And the reference is here for this methodology. So this was done in 20 countries, and we did a hybrid sampling of 120 facilities per countries, and in Nigeria it was 240. And a set of methodologies were used to measure those 11 indicators, primarily focusing on the focus on measuring integrated people-centered high-quality services. The methodologies used were facility observation, staff and patient interview, client record interview, and the average cost was about 70,000 per country. And all these details are in the reference that I've provided below. It is probably not available yet, but should be in the next few weeks, the specific article that I have referenced at the bottom. So we ended up doing this targeted health facility assessment in 20 countries, about 2,500 health facilities, and about 8,500 antenatal care records. The list of countries is on the slide. So these are the 20 countries. And the implementation was done between May 2024 and May 2025. And we used 2 data collection agencies in coordination with the country teams and the ministries of health as part of the grant monitoring that Global Fund does for the grants that it distributes. And in this case, it was the grant cycle 7, part of this 2023-2028 strategy cycle. This is some detail on how we did quality assurance on this data collection in terms of pilot testing and intensive training, both during and after the data collection, as well as independent data quality assurance in 4 out of those 20 countries to actually make sure that the data is of sufficiently good quality for us to make inferences for grant monitoring for the Global Fund. And these are just sort of summary of I mean, in the interest of time, I don't have all the results here, but For the 4 key performance indicators, as well as the 7 programmatic indicators, what we saw is that, as you can see in the KPIS one, which is measuring the integration and people-centered care, TB screening and hemoglobin testing was low at ANC, blood pressure, iron, folic acid. IPTP provision was high. Initial TB screening lower for ART clients. So we got very specific findings, and these are quantitative numbers, which you don't see. I'll show it, some of them in the next slide. And in terms of patient perception of quality, patient reported quality, while there was high levels of satisfaction with the respect and care, but in terms of big gaps in social support and access. For supportive supervision, again, there is high rates of supportive supervision as reported by the facility staff and the facility in charge. Um, Going into specifics of what that supportive supervision included, and then we had country by country level facility type. Similarly, for specifically looking at service integration for pregnant women, KPIS 3, sort of ART for HIV positive pregnant women score higher in most countries, TB screening lower. So very um, specific data we were able to generate for the Global Fund grant monitoring. And in the interest of time, I'll briefly mention the CHW indicator KPIS 5. So in this data set, across the 20 countries, there were 57% CHWs had a contract, but then in terms of these contracts lacking details on the benefits, in terms of over 80% paid for their work, but payment timeliness was a concern in specific countries, job aid stockouts, again, very specific findings and recommendations that came out of it. And then I'll leave the programmatic indicators for a minute. So in terms of, I'll focus specifically on the summary of the integrated people-centered quality services. So there are different domains. You can see this D1, D2, and all those details are in the manuscript in the paper that I mentioned. So you can see the details there, and as well as the questionnaire. But in terms of, we measured the recorded treatment and counseling, as well as the patient-centeredness, and we could specifically see which aspects of HIV, TB, malaria, and broader primary healthcare services were being offered in an integrated manner and which were not. We were also able to do some association analysis for looking at supportive supervision, guideline availability, and diagnostic capacity being the strongest predictors of service integration, more so than staffing and infrastructure alone, and findings on community health workers and lab diagnostics as well. So what this allowed us to do is to use these results first and foremost in the country level discussions to target the grant cycle 7 and 8 investments for the Global Fund. We used it to refine the RSSH framework that I showed you earlier, and which investments can have the most impact in improving service integration, service quality, thereby the disease outcomes. We were able to provide guidance and suggestions on that as well. And then what should be prioritized in measurement in future rounds, because this is over the strategy cycle. What I'm talking about is just the baseline round. Just the last slide. What we did here was we started with a framework, not necessarily a questionnaire. What we were trying to measure, we were trying to measure the strategic objective for the Global Fund around integrated people-centered quality of care. We're looking beyond structural readiness on process quality, integration, patient experience, as well as do it in a low-cost manner, but ensuring rigor. So rigor and pragmatism are not necessarily opposite. You can do it at a relatively lower cost, and building the feedback loop from the beginning itself. So this is not a one-off thing, but working closely with the countries, working closely with the Global Fund country teams to use this data and evidence for decision making as they monitor and modify the grants that are given, that are allocated to these countries. And with a strong buy-in from the country level Ministry of Health, and using these findings for not only the Global Fund grant framework, but getting national level measures on service integration, people-centered care, and quality of care. So sorry, I rushed a bit in the interest of time, but I'm happy to answer questions, and we'll share the slides as well. So I'll stop here and hand it over back to my colleagues at IPHC. Thank you.
Thank you, Dr. Shivam, really for your very clear presentation and finishing in time as well. So I think participants, you will have time to put your questions. Please put your questions in the Q&A, and then he will come back and give answers to your questions. Now we'll go to the second presentation. First, I will introduce Professor Gashaw, and then he will start his presentation. Professor Gashaw Andarge is a Senior Implementation Research Advisor at Project Hope, Ethiopia Country Office. Professor Gashaw is a Senior Research and Implementation Science Advisor at Project Hope in Addis Ababa, Ethiopia. His work focuses on translating scientific evidence into policy and practice while strengthening primary healthcare systems. He has led numerous research, training, and policy initiatives in Ethiopia and internationally. His expertise spans from implementation research, community-based health programs, to maternal and child health, non-communicable diseases, and the integration of palliative care into primary health care. He has authored numerous scientific publications and remains committed to advancing evidence-informed decision-making. So the floor is yours, Professor Gashaw, and then you can start your presentation. I think he'll be presenting the Ethiopian experience of pathways segmentation, which is important, probably a newer approach. And we'll have that presentation just now.
Thank you very much, Professor Getinnet. Thank you very much, PHC, for the opportunity to present our project work at this global webinar. We are very much grateful to the organization, my team and myself, and the Project Hope is really grateful for the opportunity, and Tirsit as well for facilitating to make this opportunity. Can you hear me?
Yes.
Thank you. My presentation, my current talk will focus on, as it was said, pathway for Ethiopia, understanding multidimensional vulnerability to maternal RMNSH plus nutrition outcomes, and translating evidence to action. So this project is funded by Gates Foundation, and the project period is 2023 to August 2026. But since the implementation part is not really yet started, we have got extension for 1 year time. So as a justification for this project activity, as we know, Ethiopian Initiative Primary Healthcare was successful in many kinds of health indicators as a national level, but inequality in RMNSH plus nutrition remains as a major concern studied by different scholars like Asafa and Danu in 2024 and 25. Regarding socioeconomic and geographic inequality is something critical issue in the country. If we think of about some of the critical indicators with the maternal child health issues, if we just remember there are a number of disparities, like if we consider immunization across the regions of Ethiopia, there are a number of disparities in achieving immunization coverage across the countries of Ethiopia, and there are inequities across regions in terms of socioeconomic activities. Disregarding health inequality would really lead us and undermine principles of social justice, and that would really lead us promise compromising impact on RMNSH plus nutrition interventions. So, in saying that as a critical problem, pathway method is really an analytical method which is popularized by Institute of Disease Model, International Disease Model, Institute of Disease Modeling, which is founded by Gates Foundation, which is a population segmentation based on social determinants of health, and vulnerability based on segmentation of the population. On this regard, population segmentation is dividing the larger population into smaller and homogeneous groups based on compounded vulnerabilities, and identifying distinct segments that can be targeted with tailored intervention and reduce inequality among the target population within the country. So that would really focus, as already said, RMSH plus nutrition outcomes, and being implemented this project in multiple low-income countries. So the whole essence of segmentation in population segmentation would really lead us, precision public health. Unlike the previous research activities, we are focusing on to reach precision public health interventions, which is tailored kind of intervention for the target population. As you can see from the diagram, there is as a research process, this population segmentation would try to identify risk population among the target population, and those sorry.
Are you disconnected?
No, I'm not disconnected, but my slides are not visible at this time. I don't know what happened.
They are not moving. So
you maybe click on maybe click on the center of the slide and
Oh. Sorry. I don't know what happened.
Maybe Bro, you can.
Could you please?
I can share the slides.
Yeah. It cannot move, please.
Yeah. So do you want me to continue?
I just, I've left with the previous slide, bro, please. Yeah, thank you. Thank you so much, bro. So as you can see from this diagram, it tries to identify risk population based on certain vulnerability factors to identify and targeted intervention so that it improves the resource allocation and integrating social determinants into health service delivery population. So next slide, please. Yeah. So pathway process is really will try to help us, as I said already, exploring vulnerability impact in RMNSH plus nutrition key indicators. And this process would try to segment population based on certain vulnerability factors. And that would really lead us evidence-based policies, program, and intervention activities. Next slide, please. So these are, some of the vulnerability domains of the process, how we have gone through to identify vulnerable population. So these are the 6 dimensions of vulnerability. If you can see from the diagram, the first one is women and her past experience, and also household relationship, household economic and living condition, social support, health mental model, and human and natural system are some of the compounded vulnerability areas where we're just focused to identify vulnerable population. Next slide, please. So the goal of the investment was to identify factors that makes Ethiopian women and girls vulnerable to poor RMNSH plus nutrition outcomes. And based on this, to develop vulnerability segmentation solution for Ethiopia for these two target population and intervene to effectively reach segment of the population according to their vulnerability. And the last goal of the investment is to provide building model capacity for the ministry, and at the same time, people who are really working in the universities and research areas. Next slide, please. So what is the peculiarity of pathways to Ethiopia? Is the first one is a full pathway model, which tries to consider from identification of vulnerable population to implementation of key interventions or tailored interventions to selected target population. And the next one is horizontal segmentation based on multiple RMNSH plus nutrition outcomes. And it is also mixed method design and separate segment for women of reproductive health and adolescent girls, and gender-related factors as a major domain for vulnerability, and implementation research is key issues. And lastly, but not least, capacity building for those target population, as I already mentioned. Thank you. Yeah. So these are the 4 phases that we follow to implement this research activity. The first phase 1 is systematic review, geospatial analysis, and qualitative research 1 was conducted, and to identify key contextual specific source of vulnerability that we're going to see, we have seen earlier. And second one is secondary data analysis, which was taken from EDHS and other national data for variable mapping. So the outcome for this one was capacity building on pathway fellows methods capacity building, and finalizing variable mapping for the national survey. And the third one was doing the survey for two target population, and the other one is second qualitative research is just planned to segment solution and to develop typing tool, and finally to undertake mechanistic models. And the fourth one is identification and testing of interventions based on the critical identification of target populations. So the evaluation of the intervention would focus on selected regions and selected districts of the country. And finally, as a result, to develop and validate it of tailored and human-centered design would be used. Next slide, please. So this is some of the steps that we have gone through, to identify those vulnerable populations. These are the 9 steps of how we have gone through it. So I will be sharing this slide so that you can see all the details of this activity. So we can go to the next slide, please. So the typing tool is mobile-based apps that assign individuals to a predefined pathway segment based on Ethiopian segmentation solution, and allocation powered by decision tree analysis, and serve as practical job aid for frontline health workers. And the tool accuracy is greater than 80% for sensitivity and specificity of the tool. Next slide, please. So what are the key activities so far completed? As I already mentioned earlier, understanding RMN source of vulnerability in Ethiopia was undertaken. Some of the things that we have done is we did geospatial analysis. We have done secondary data analysis of DHAs, systematic reviews of literatures on these issues, and done national qualitative study for both study populations. And the next was variable mapping and development of study tools and adaptation of tools from the global experts, and development of adult survey tool was done. And later on, implementation of 2 national surveys, as already mentioned, and the study participants were around 10,000 in both study groups. Please to the next slide. So stakeholders engaged in the process was PHI and NDMC from the Ethiopian perspective, and at the same time Ministry of Health, Maternal and Child Health Adolescent Directorate, Policy Strategy Research Lead Office, and other LEOs are involved to understand the importance of the project and to engage in the different steps of the research project activities. Please, the next slide. Yeah. During the engagement of the strategy, working in the proximity with Ministry of Health and the PHI, excitement and willingness to embrace pathways and ministry-owned and government-led process, and early engagement of stakeholders like, as I said, Ministry of Health, the PHI, and MC engaged in starting from inception and engaging key personnel as co-investigators from the ministry and at the same time from EPHI, and engaging stakeholders in co-creation of intervention design are really underway at this time. Please, to the next slide. So these are the critical variables that were used to identify vulnerability used for segmentation solutions for the urban and rural populations. So these are around 40 around 35 to 40 variables that being used to segment the vulnerable population from the rural and urban segment of the population. Actually, the variables that we have used is more than 1,000, but we try to go a long process to reach to this level, actually. To the next slide, please. So this is the result part of the pathways segmentation. As you can see, population segmentation for women of reproductive age, reproductive groups. If you try to see the rural part, you can see from the bottom that yeah. Yes, from the rural populations, you can see we have 5 segments of population. Our analysis tried to segment population into 5 segments. You can see 1 is least at risk, and 2 is moderate risk, and 4 is more at risk, and 5 is least at risk, and 3 is most at risk population. So we can understand that our segmentation solution try to identify the rural population is not homogeneous. So it was really heterogeneous, and we try to divide into 5 groups of target population, so that if we try to see from the picture, 8.5% of the population among the rural population is high risk for a certain health problems. And if we try to see 20.7% is moderate at risk, and 33% are least at risk. So that we can think about how much resources are really required to invest to address these health problems among the rural population. When we come to the urban population, it tries to divide it into 4 groups or segment of populations. The first one is most at risk, and 2 is moderately at risk, and the 4th segment is moderately at risk, and the 3rd is least at risk. So that still 14.2% of the population are mostly at risk of getting a certain disease burden. Next slide, please. So when we come to a specific kind of indicators, you can see CPR, ANC, skilled birth attendance, ANC, PENTA 1, PENTA 3, and diet diversity, and other kinds of indicators among the urban population. You can see it tries to segment into 4 groups, and 65% of the population at the rural population is at risk of not getting CPR services. And when you try to consider ANC, 92% of the population are not really attending ANC 4. So you can see how much the segmentation solution try to differentiate target population for certain interventions. If we try to see under 5 mortality, it tries to range from 7 to 52% per 1,000 live births, so that the risk of getting under 5 mortality varies among the different target population. Next slide, please. When you come to rural population, as already mentioned, it tries to segment among 5 groups. So you can see from the under 5 mortality is ranging from 32 to 75 per 100,000 live births. So you can see the diversity of under 5 mortality among this rural population, which means rural population, under 5 mortality in the rural population are not really the same. It varies from 32 to 75 per 100,000 live births. So that, the intervention we try to think about is based on the magnitude of the problem. But by the same token, if we try to consider CPR, ANC, skilled birth attendance, early PNC, Penta 1 and Penta 3 is segmented among 5 subgroups, and you can see the variation. For example, CPR is the least is 7 and the highest is 52. And the same is true for the rest of the indicators. The next slide, please. If we try to see segmentation based on geographic distributions among rural segment of the population, you can see still we have 5 segments among the total population, the rural population, and one is the green one is least at risk and moderately at risk, and the 4th is most at risk and least at risk. So the 3rd one is most at risk. Okay, I'll be finishing in 2 minutes, so that you can see geographically the variation among the different populations. If you try to consider the urban segment of the population, still we have 4 segments, and you can see the magnitude of the problem among the different regions of the country. So the green one is most at risk, so that you can see where we can really tailor our interventions. Next slide, please. So, these are some of the alignment we did with the national and sectoral priorities. We try to work very closely with the Ministry of Health to provide, scientific inputs for designing the national planning for HSDPI, third, and promote precision public health. And we provide also pathway fellow recruitment and PhD level training initiatives, and we provide also disease model training for people who are working at the PHI and as a ministry level. Next slide, please. Just finishing too. Some of the lessons and innovations have already made some of them, like segmentation solution is revealed hidden inequalities beyond the rural and urban divides, and it tries to provide us precision public health that enable targeted and tailored intervention for the target population, and also typing tool was emanated from this segmentation solution, having 15 to 16 questions to identify the level of vulnerability for the target population, and the level, total tool accuracy is, I've already mentioned, 80 and above for sensitivity and specificity. And the good practice is also, presented over here so that everybody can see it. Next slide, please. So the conclusion and the way forwards, Ethiopian pathway analysis explored and measured context-specific source of RMSH vulnerability and provide national data for segmentation, and also identify gaps in the national RMSN landscapes, and vulnerability based on segment analysis provide revealed hidden agenda inequity beyond rural and urban, and demonstrate strong discrepancy, discriminatory power to identify a segment of the population. And the next one is actually, thank you very much. Yeah.
Thank you, Professor Gasha, for your elaborated presentation. I gave you some more minutes, and thank you for your presentation. Now, I think you can look at the QA section. There are questions. Probably the first one is to Professor really Gasha, I think the first one, and the second one, maybe, yeah, both of you can answer the second one, but probably to Professor Gasha again, but both Dr. Shivam can also can talk about it, I think. And there is another also, a third one by Dr. Iskender. So you can respond to these questions. Maybe we can start with Dr. Shivam. Do you want to answer any of this first?
The only thing I can
Yeah.
comment on is the second question from Hymanot Belay. And again, so I mean, the question is actually towards Professor Gesha, but this issue of secondary data sources and incomplete, inconsistent secondary data sources, and how does that affect any measurement, or in this case, the work that I was talking about at the Global Fund. So part of the reason, since the secondary data sources on measuring primary healthcare service delivery, integration, or quality of care, typically do not have that information. They are incomplete, inconsistent in terms of measuring service integration and quality of care. That is the reason why we had to customize and design a tool from existing tools, the service provision assessment and the service readiness assessment. But sometimes secondary data is completely inadequate or incomplete. And in the case of the example I talked about, that was indeed the case. So we had to come up with the new data set, which we are now trying to, since we work very closely with the Ministry of Health, these type of questions on service delivery, integration, process level quality are being incorporated in the routine HMIS systems of these countries, which will allow secondary data sources on service integration and quality of care. So that's one question I could sort of answer from my perspective, but I'll hand it back to Professor Geshau in relation to this question and some of the other questions that are in the Q&A section. Over to you, Professor.
Thank you very much. I can see, I don't know, Tosfai Shiparo has already raised LCA. Whether we have applied latent class modeling was being used as a segmentation solution. To say something about this issue. Yeah, thank you, Tasfai, for raising this important point. Yes, whenever we think about segmentation solution, this is the most important analysis being used to segment population, to identify homogeneous and small group of population which are really expected to have homogeneous characteristics and behavioral aspects and health access issues. So latent class modeling try to try to identify unobserved characteristics of the population being used to identify based on observed characteristics of a certain population or key indicators. So there are a series of steps actually to reach to this level. The first one is, we expect to do exploratory analysis, and we go for principal component analysis. And the last step for segmentation solution is LCA, which is identifying unobserved characteristics of the population based on observed indicators of indicator measures. So that's really an important point, and we have gone through it to reach to this level. And maybe the other question I can see in research data collection is critical components that chosen on when using secondary data source. Research often encounter incomplete or crowd. How do you recommend balancing or addressing? Yeah, there are actually we have used not only secondary data, but we used primary data for our segmentation solutions. We try to exercise actually secondary data ADHs, and we try to apply those techniques to impute data to avoid missingness and the like issues. So because in segmentation solution, if a variable does not have any observation, it tries to eliminate from the analysis. So, but in our cases, we have a primary data, which we try to maintain the quality of the data to avoid its missingness and all other critical problems. And how would you handle dynamics nature of vulnerability? Yeah. Vulnerability is so dynamics. We try to, as I already mentioned, if you just remember, we have 6 domains of vulnerability. The woman and her past experience, and family relationship, and household economic and living conditions, social support, and human and the natural system. And at the same time, we try to use actually health mental models. So we try to see all these vulnerability domains, and we try to manage to address the critical vulnerability of each segment population, and we try to test it by applying whether the data can really fit into a certain group of the population to segment and level whether the population is segmented at a high risk or moderate or less risk, and so on and so forth, so that we try to see those issues. And testify also, so no LC applied, but typing tool use, no. As I said, we try to apply LCA, and finally, typing tool is applied after the LCA. And secondary vulnerability is very common in pastoralist conflict affected or remote areas because of weak infrastructure, limited service. So how this will represent in the study? We try to characterize all segments of the population across the different regions of the country. infrastructure is one of the vulnerability factor, but it's not the only factor that we considered. As already mentioned, we try to consider the six domains of vulnerability factors so that you can see from my presentation. And Yaret, maybe are the vulnerability measures comparable across urban and rural? No, no, that's not the intention. We're not really comparing urban and rural. We're comparing, among themselves. If you just remember my presentation, urban population segmented or divided into four segment population, and the rural part is among 5 segment of the population. So there was no any comparison between the rural and urban population. And very much was present for you. So that was some of the questions I've seen from the chat box. If you could have any more other issues or anything that I would like to add, you can still raise. Thank you.
Thank you. Thank you, Professor Gashau. And maybe until other questions come, I would give a couple of minutes, maybe 2 or 3 minutes to Dr. Shivam, if you want to emphasize some of the things that you presented or anything missed, because we have a couple of minutes that you can use if you feel that there is an area that you haven't addressed.
Yeah, thank you, Professor Gednet. So I think, I mean, the topic of the presentation, or the sort of the rationale in terms of using research or using evidence for decision making, using measurement for decision making. In the case of the Global Fund example, the sort of the rationale of the work was trying to fill a measurement gap on health system outcomes of service integration, quality of care, and people-centeredness, which aligned with the strategic objectives of the Global Fund. So here was an opportunity where we had a gap in measurement and gap in evidence on related to primary healthcare outcomes. And strategically, we got an opportunity to fill some of these gaps through the Global Fund mechanism, thereby providing a sort of a practical operational example of generating evidence which could be used directly for decision making for Global Fund grant monitoring, as well as in-country decision making in terms of improving the service integration, service quality. I mean, this applies to primary healthcare in general, but in Global Fund's case, we were specifically looking at HIV, TB, malaria. So the idea was to use an opportunity where we could use evidence to implement things as they were happening in real time. So this was the work presented is not necessarily a research study, but it is a implementation research done in a sort of a live real setting, whereby decisions, there was a measurement need, and that gap was filled to help countries and the Global Fund Secretariat to make decisions on improving the grant performance and disease outcomes. And the other thing I can say for that work is that the idea was to do longitudinal measurements, in the sense what I presented, what I the design and implementation and some baseline results are presented, so data collected in 24-25. The intention is that in several of these countries, this type of measurement of service integration, quality of care will be repeated again during the current strategy cycle, which ends in 2028, thereby providing Global Fund and country partners another 1 to more data points to allow measurement of change in service integration, service quality, and people-centeredness, and the support for community health workers in countries. So as I said, it's a sort of example of implementation research on PHC measurement and allows real-time decision making with provision for longitudinal measurement in a good set of 15-20 countries. I can also, if there are questions, I can talk, but these countries were identified because of the high volume of investments that these countries had on their health system strengthening. So Global Fund invests in more than 100 countries, whereas these 20 in their grant portfolio, a good proportion of the investment was focused on health system strengthening. Therefore, we sort of narrowed down to this smaller set to do these measurements to see if there are any changes that happen in service integration, quality of care, and support for community health workers over time. So, I mean, that's just sort of additional context on what I presented. You can have slides, and then if colleagues have questions, I'm happy to answer through email or Zoom calls later on. And then the article I referenced on details of the process is currently in press and should be out by the end of this month. So that's what I can say, Professor Getnet. I'll hand it over back to you.
Thank you, Dr. Shivam. Maybe, yeah, for Professor Gashaw, if you have anything you'd like to say, then I'll try to focus
Thank you
on
very much, Professor Gaten. Yeah, thank you. Actually, it's just a golden opportunity for us to highlight and to to present this kind of work, which is really of its the first is of kind. Actually, unlike, as I said, unlike the previous studies, what we did so many times, puzzle segmentation is really a kind of study which is really depend on vulnerability rather than focusing a particular variables, which means it tries to focus on compounded vulnerability of a certain population. So I think we have a lot of things done to come to reach to this level. Maybe time constraint might not be really able to make most of our our work, so that everybody can really reach out, all of us at Project Hope, or you can write us an email, so that we can respond to your questions, and we can share all the details of our presentations and work at the same time. So, Prof, this is really a golden opportunity for us to share some of our works. Thank you very much.
Thank you very much. Maybe to talk about a few points that you have already mentioned. From the global perspective, Dr. Shivam's experience was also, it was very useful, particularly on HIV, TB, and malaria. One of the things he emphasized is really linking investments with outcome, which is very important. Not only interventions with outcome, but investments with outcome. and high impact investments as well, high impact interventions as well. So we should really focus on outcome and processes. If we are looking at outcome, short-term outcomes, medium-term outcomes, long-term and impact, we should see all this. And quality is really a driver for outcome, which is a very important, not access, which is a very important thing. And I think we have to consider this in our programs. The other area is need for measurement. We know about measurements and indicators, but also emphasized on KPIs as well as programmatic indicators, process as well as outcome indicators. And then ultimately, I think whatever we do is for decision making. So we should not really do for doing research purposes. If this is an implementation research, then there should be an action. So there should be ways to reach out to decision makers, which is a very important aspect of these kinds of research activities or implementation research. The second one from Professor Gashaw, I think the Ethiopian experience, the importance of segmentation, like inequality is a very important problem in our country, in all countries actually, but in our case also, rural, urban, very big gap, and also pastoralist and so on. But what he's saying is that is not enough. I think it's not the things we do, as visual are not enough. For instance, urban-rural comparison or comparison by age, or these are not enough. We have to look into behind for latent variables and segment that and identify what's behind urban, what's behind rural, why this is happening, and who are at risk. Although the group is the same, who are at risk compared to the other groups or the other segments. I think that's a very important thing. And he called it precision public health, which is very important as a tool for implementation research. And in exploring vulnerabilities, again, segmenting, producing evidence, and doing the risk-based approach or categorization, and then our interventions can be our investment now, linking to the first presentation, our investment can be reasonable, or the return could be really good as well, because we can identify high-risk groups and low risk groups, and we know where to invest our limited money. And also, the most important thing is in stakeholder engagement, which is very important, including the ministries or the policymakers and other partners working together with our projects, which is, after all, this is an implementation research, so action is required again. That's another message that we have heard. Finally, I would like to thank both presenters really from Global, which is really very rich in, we know, in those big investments, TB, malaria, and HIV, the evidence, and then for decision making again, and two country level really example or experience in segmentation, pathway segmentation. So I would like to thank both presenters really, and also the participants and the organizers as well. Thank you very much. Really, it's wonderfully organized, and thank you for the questions as well. Thank you, and I think have a good day or evening. Thank you.
Thank you very much.
Do you have anything to say? If Tersit is there.
I think, Prof, you have concluded it very well. Thank you so much for the excellent moderation, and also thank you, our panelists, for sharing these insightful presentations and also for addressing all the questions. Thank you, Prof, for your wonderful moderation again. And yeah, have a good day, everyone. Have a good evening.
Thank you. Bye.
Thank you.